Hello, hello, hello. I am retaping this talk. I've actually broken it into two separate talks. And so here we go on women's health. We're going to start with contraception. The woman in the background is someone that may have impacted your life more than any living or dead human being. I'm not going to tell you who she is until the very end. And unfortunately, she did have some real downfalls as far as her political beliefs, but she may have had a major influence on you. She basically is responsible for the development of the oral contraceptive. So I'm going to fly through some basics, mostly focus on the pharmacology. Contraceptive, there's no one great method of contraception. Each option has pros and cons. It's not easy to decide. People need to get educated. We need to be able to educate them and help them make these decisions. They often will take our recommendations. And they also need to know that birth control options fail, and that if you've been careful, though, the odds of that are less. So depending on a person's health and age, if they're older, if they smoke, there's going to be certain contraceptives that they're going to want to avoid. If they don't want children in the future, we can use a permanent contraceptive. We can actually use sterilization. If they have a number of sexual partners, they may want to use condoms just because it also protects against sexually transmitted infections. Um, and we'll talk about how each of these methods prevents pregnancy and also a bit about the side effects. So, abstinence, natural rhythm, barrier methods, hormones, and different types of pills and non-pills, and implantation, meaning the rod that you put under your skin, and then sterilization and contraception, emergency contraception. So abstinence, this has been promoted by a lot of people. Theoretically, it should prevent pregnancy. Unfortunately, the data is pretty unimpressive, and we do find that most students that are in an abstinence-only program initiate sex at the same frequency, at roughly the same time, with the same risks of STDs, with the same risks of pregnancy. In fact, as you can see on this slide, there does seem to be slightly higher STD rates among those that used abstinence only. So natural rhythm, you basically need a woman who is very motivated, who can figure out when she basically is ovulating by either using temperatures or monitoring her flows. But if a woman really does this effectively, she can decrease her risk of pregnancy. Although it's still a substantial number of these women do get pregnant, but some women conceptually don't agree with using hormones. There is some interest in using cervical mucus, that's spinbarkite. Um, I'll let you learn about that in one of your women's health rotations because that's not really exactly pharmacology, but just to mention it here. So the barriers, this contraceptive sponge wasn't available for a while. It's not that easy to get now. You probably have to order it on the internet. It's between $4 and $12 per sponge. But basically, it's a barrier method. It contains some spermicide and is moderately effective. Probably has a 10% or so failure rate after a full year. Cervical cap actually has a slightly higher failure rate, even though you'd expect it to be better. This is where a woman puts a cap over her cervix, usually with a spermicide, but unfortunately, due to the pragmatic issues of actually using it, it often is not as effective. The male condom is something that pretty much everybody's familiar with. Usually you use them with a spermicide if you can. Not very expensive, available in any grocery or drugstore. Female condoms are a little bit harder to find. They're about $2 a piece, and they have about a 5 to 21% failure rate, depending on the effectiveness of the user, how well they use it. So they are available. I very rarely hear of women. I have a couple of women who do use them, but you need a very motivated woman to use those. Hormonal methods, so basically these are predominantly the pills. You can also get them in a patch or a ring. They stop ovulation, and they change the endometrial lining so that it's more hostile to implantation. One of the things they also do is they change the pH of the upper genital tract, mostly the fallopian tubes, to prevent the sperm from accessing that area. Most oral contraceptive pills are taken every day and then skip 7 at the end of the month. There is real interest and real value, I think, for many women to take 3 months worth and then have a period every 3 months. Does not seem to be any increased risk of cancer. Most women are very happy about this, and so it is something that is definitely worthwhile discussing with a woman. Lots of side effects of estrogen or progesterone. Each one is slightly different. The progesterone is more likely to cause androgenic type effects depending on the type of progesterone. And so women will get acne and hirsutism and oily skin. The problem, of course, is that the androgenic component is usually the component that helps with sexual interest. And so if a woman is not all that interested or has decreased libido, they might want to have increased androgenic effects. So it's always a balance, looking at the side effects and the potential benefits. You can find charts of the various pills of what has high estrogenic effect, what has high progestin effect, and specifically what has high androgenic effect. So women normally would not take a oral contraceptive if they're over 35 and smoke, if they have a history of blood clots, a history of breast, liver, or endometrial cancer. Interestingly, a history of a liver mass, even if it's non-cancerous, and also women that have migraine with aura are usually not candidates for pills. So as we noted, we choose based on those effects. Each one has a different potency, and so you're going to be able to adjust it depending on if she's having heavy bleeding, light bleeding, etc. There's lots of different type of progestins. Lots of times we classify pills as first generation, second generation, third generation, and fourth generation based on the progestin that they have in them. And again, I'll encourage you, if you are going to prescribe a lot of pills, to review all that. It's always hard to decide how much to cover this because for some of you, this is going to be your bread and butter. You're going to do a lot of prescribing. And for others of us, we really do this fairly rarely. So one place that most of us start is to look at the pills that are on the Walmart $9 list. Sprintech is the monophasic pill that is on there. Almost all women can do a monophasic pill. The only real reason to go to a triphasic pill is if a woman's having side effects. And even then, there's arguments as to whether they're any better. So most of us will start with this monophasic pill. All oral contraceptives are estrogen type 2. Each one has a slightly different amount of progesterone effect / androgenic effect. And again, the triphasic pills, there might be less spotting, maybe less side effects. Although now that the monophasic pills are pretty low estrogen, there's really not a dramatic difference. Most of these triphasic pills, and there's also biphasic and quadriphasic, but most of them were used before the pills became lower estrogen. So as noted, just make sure you look at the charts and see what has high estrogenic, progesterone, or androgenic effects. Here's a little chart that you can look at. You might want to even pause here if you're very interested. And it does talk about the various types of side effects and how you would then want to adjust the pill. So if the woman's having excessive estrogen activity, you choose a pill with lower estrogen effects. and so on. Now, there's three types of estrogens, and essentially these estrogens in these combined hormonal contraceptives are the E2 type. I'll talk more about the three types when we do the menopause talk. I'm sorry, the menopause talk. But just suffice it to say that there's different ones. If we're doing topical preparations, we may use a combination, but again, that's used more for menopause. The progestin only pill or the mini pill, there's also a ring version of this. It does suppress ovulation. The problem with these pills is that they have to be taken at the same time every day. And you really need to make sure it's within a few hours at the very least. Even a few hours may make it less effective. So breastfeeding is not a contraindication for these, though. So a lot of times women that are breastfeeding that want contraception will use the mini pills. But the overall risk of pregnancy is substantially higher just because they have to be taken so religiously and without fail, or they may have problems. Side effects, they tend to have more bleeding, and they'll also sometimes have ovarian cysts, flare-up of acne. Again, the progesterones tend to have more androgenic effects. You can use a progesterone injectable. Depo-Provera is given every 3 months. It basically does the same thing. The biggest side effect or the biggest concern with the Depo is weight gain, although there is also concern about decreased bone density if you use it for more than 2 years. Generally, we try not to use it for more than 2 years, but you need to make sure that you've done informed consent if the woman is going to do more than 2 years. Implanon and Nexplanon are basically the same thing. Nexplanon is sort of the newer version. And basically a small incision is made in the upper arm, and it's inserted there, and then the progestin releases over time. The older ones were a little hard to get out. The newer ones are a lot easier. They give, I think they're 10-year. I would actually have to look that up to be sure. But they're a good, long, effective birth control. And many women do like these, although they do have those same progesterone side effects. The Copper Iud does not have any hormones in it. It basically stops fertilization, and it probably stops fertilized eggs from implanting, although that leaves it open to a criticism of being a abortifacient. Women continue to get their periods, unlike the hormonal IUDs, and they're often heavier. So I have a lot of women that have had these put in and then taken out again, just because they did not tolerate them well. If a woman doesn't have heavier periods, it is hormone-free, and that's very appealing to some women. The Mirena is a low nogestrol IUD. So it basically stops the periods. A lot of women have spotting for a few months after they're inserted, but usually they then stop their periods. That's one of the reasons we use this very frequently in women that are near menopause, just because lots of times those women have already started to have problems with frequent periods or excessively heavy periods, so-called menorrhagia and metrorrhagia. And so lots of times we'll put them in at that time, gives them contraception, also gets rid of their periods. Some people will check an FSH when they're getting ready to take it out to see if the woman is in menopause at that point. But it is a challenge to figure out when a woman goes into menopause if they're already not having periods because of Mirena. The Skylar is 3 years, but it's lower dose, and the Loletta is now rated up to 6 years. Many women, after about 5 years, they'll still have some contraceptive benefit, but they'll start to get spotting, they'll start to get periods, and it'll often be an indication to them that they're due to change out their IUD. 3 to 5% of all IUD users will have expulsion, just falls out. and that's as high as 5 to 22% in adolescents. We are using them more in adolescents now because they are smaller, but they used to just be used for Paris women, for women that had had a child. And this isn't a very clear slide, but it gives you the idea that the Skyla is a little bit smaller, and the Mirena, of course, is a little smaller than the Paragard. And so each one is slightly more difficult to insert and maybe a little bit more likely to cause irritation and heavy bleeding. But you can see there's not a huge difference in the size of them. The Sure is no longer available. It basically was a spring that was placed in the fallopian tube that then caused a lot of scarring and basically caused sterilization. It worked pretty well for sterilization. The problem with that was that about 75% of women started having pelvic pain, and so that it really is not a viable method of contraception if women have a lot of side effects. And so the women that have them in and don't have any side effects can leave them in, but women that are having any side effects may in fact end up having either a salpingectomy bilaterally, or maybe even a hysterectomy, depending on the placement of the Sure. And surgical sterilization, I'm sure you all know what that is. You know, there's usually laparoscopically, there's a probe inserted that then burns the fallopian tubes and separates the two ends, and it's therefore stops the egg from getting fertilized and getting down to the uterus. Does slightly increase the risk of a ectopic pregnancy if the egg and the sperm somehow find each other. This is a picture of the Assure. You can see that there is that spring, but as noted, they're really not used much anymore. Emergency contraception. There's three major types. The most common is Plan B or Next Choice. That's when a woman has unprotected sex. She goes to the pharmacy and buys this over the counter. And she has to take it within 72 hours. There is a method you can use up to 5 days, which is 120 hours, but that one needs a prescription, the ulipristal. It's also called Ella. Theoretically, girls should be old enough to consent to sex, which in Maine is 16, unless there's 2 years lesser difference. So if a 14-year-old has sex with a 15-year-old, that's okay. But if a 14-year-old has sex with a 17-year-old, that's statutory rape. In New Hampshire, the age of consent is 16, period, no exceptions. And so you really do need to know what the age of consent is in your state. But either way, sometimes there are states that do seem to still require the 17-year-old, which is the way it was when it first came out. But in general, most states have actually backed off from that. You can insert a Paragard up to 5 days later as well, but now that the Ella is available, they tend to do that less. This is a chart. Again, if you're very interested, you're welcome to pause here and look at it. Approximate cost is coming down some, but it's somewhere in the $30, $40 range for the majority of these. And this is Margaret Sanger, who was the woman that basically investigated and funded the development of the birth control pill. First birth control pills were developed in Worcester, Massachusetts. Unfortunately for Margaret, she also tended to support the concept of eugenics, which is using birth control to try to select out a better race, and probably meaning white folks, and especially European white folks. She tended to think Hitler was kind of an okay guy because he was trying to support development of a master race. And unfortunately, this really did kind of mess with her credibility. So she made some big mistakes there, but on the other hand, she really did make some decisions and some funding impact that really has changed the life of essentially every woman on the planet, and therefore every man as well. So that finishes the talk.